Hi everyone, this is Emily, and I'm going to be presenting on atrial fibrillation. So my objectives are to know the risk factors for atrial fibrillation, understand the pathophysiological insult, recognize the clinical manifestations, identify the diagnostic criteria, and understand the guideline-based recommendations for treatment. So what exactly is atrial fibrillation? Um, Atrial fibrillation, or AFib, is characterized by structural or electrophysiologic alterations of atrial tissue that promote abnormal impulse formation and or transmission between the atria and the ventricles, making it the most common arrhythmia. So when I was doing some reading, it's not really known exactly why AFib happens, but it's a miscommunication between the atria and the ventricles, causing the atria to fibrillate and not beat effectively. So there's a few different kinds. There's paroxysmal, which begins and ends spontaneously or after intervention with 7 days of onset. Persistent continues for more than 7 days. Long-standing is continuous AFib for greater than 12 months. Permanent is AFib when no longer attempting to restore or maintain sinus rhythm. And non-valvular is when AFib is present in the absence of rheumatic mitral stenosis, heart valve replacement, or mitral valve repair. Some risk factors for AFib include coronary artery disease, heart failure, hypertension, rheumatic heart disease, valvular heart disease, abrupt discontinuation of a beta blocker, alcohol ingestion, hyperthyroidism, an MI, or cor pulmonale, which is that right-sided heart failure that occurs during severe COPD. Some clinical manifestations of AFib. So the most common presenting symptoms of any tachyarrhythmia are fatigue, dyspnea, and palpitations. A lot of patients are asymptomatic if they don't have a rapid ventricular rate. Some patients have angina or changes in level of consciousness and syncope due to that reduced cardiac output. Physical examination is going to reveal an irregular rhythm, sometimes with a rapid rate. Obviously, when you're listening to a patient's heart sounds in clinic and you hear something irregular, you're not going to be able to know for sure if that's AFib. If it's something new, then um, it could be AFib, it could be PACs, it could be PVCs, it could be another sort of sinus arrhythmia. So just listening isn't going to be a diagnostic factor, but it will help guide you in what to do next. People also experience palpitations, dizziness, and a decreased blood pressure and new onset activity intolerance. So for diagnostic testing, an EKG is the routine diagnostic test to assess any arrhythmia. Obviously, you're taking a picture of the heart for 6 seconds and seeing what it's doing. Um, a TEE is a diagnostic procedure that's necessary when we know we have AFib, to rule out a thrombi in the atria before performing cardioversion. Um, when I used to work in recovery room, we would do TEs and cardioversions often. They require some level of anesthesia. Um, Best practice is to do the TE before cardioversion, but I did see some providers not perform a TE first. The patients were okay immediately following, but there was one patient that we did have that did have a thrombus identified in the atria, and they went home on several weeks of anticoagulation before coming back and having the procedure again. Other tests that should be performed when a patient has new AFib is TSH. You want to check the thyroid, CBC, look for like anemias or something. A CMP is looking for really like your potassium and your magnesium levels because those directly impact the excitability of the cardiac membrane. PT-INR should be tested before initiating anticoagulation, and maybe your liver enzymes should be assessed because that can affect coagulopathy. So here's an EKG of AFib. It's irregularly irregular. You have a narrow QRS with no discernible P waves. Those are kind of the big things that shout AFib at you. And this patient is experiencing like a pretty quick rate. So the pathophysiological insult of AFib, obviously, we all know this is stroke. So they have a 2.4-fold increased risk of stroke, as does other people. Um, Cognitive impairment is another thing, dementia, MI, sudden cardiac death, heart failure, CKD or PAD. Um, Obviously, when you have a patient who has blood coagulating in the left atria, it is going to result in clots. And those clots are going to be sent out through the left ventricle into the aorta, into systemic circulation. The most common place for them to go is the brain. So when we're going to treat AFib, one thing that we want to start with is resuming normal sinus rhythm. So the initial goal is to convert the patient out of AFib and restore normal sinus rhythm. Pharmacological cardioversion is not indicated once AFib is considered permanent. So if you're going to perform pharmacological cardioversion, it really should be done in the hospital because if there are clots sitting in the left atria, once normal sinus rhythm is restored and the atria is beating effectively, it's going to push the clots right out. Um, so it takes 36 to 72 hours for clots to form. If this AFib happened like in the hospital, they're on cardiac monitor and they have AFib, and 2 hours later, you're giving them some metoprolol to convert them back. There's really low risk to have a clot there. But if they have an unknown amount of time in AFib, you've got to be careful when restoring normal sinus rhythm. So, one medication that's used often in patients, either post cardioversion electrically cardioverted or to try to get them out of AFib, is amiodarone. And that's 400 to 800 milligrams daily for 2 to 4 weeks, and then 100 to 200 milligrams once daily. Metoprolol is a medicine used for rate control. So if a patient is in AFib and we know they're in AFib, you want to prevent them from going into AFib with RVR. So metoprolol, extended release, 25 to 50 milligrams daily, and you can double that every 2 weeks if needed. Metoprolol tartrate, 25 to 100 milligrams BID, is also an option. So if your patient wants to get out of AFib, the cardiologist wants them to get out of AFib, they can perform that electrical cardioversion following a TEE to ensure there's no thrombi in the atria. Some lifestyle modifications that are going to help your patient out that has AFib includes weight loss, increasing their physical fitness level, stop smoking, don't drink alcohol. If you're going to, don't do it very much or not in excess, limiting caffeine consumption, managing hypertension, and managing diabetes. So when we're thinking about doing anticoagulation for a patient with AFib, here are some tools that you can use to help think about, does this patient need anticoagulated, and like what are the risks that we're putting on this patient with the anticoagulation. So the CHADS-VASc score is something that is used often. Um, and that's like your bleeding risk stratification, or really your stroke risk stratification. So if a patient has congestive heart failure, they get a point. Hypertension, they get a point. If they're older than 75, that's 2 points. Diabetes is a point. Um, Previous stroke is a point. Vascular disease is a point. Age 65 to 74 is 1 point. And then female gender is 1 point. So for patients with AFib and an estimated annual thromboembolic risk of greater than 2 in men and 3 in women, anticoagulation is recommended. The has bled isn't necessarily something that's going to stop you from ordering anticoagulation, but it's going to make you think like, what are the risks? Is this patient a good candidate to receive this medication versus this medication? And it's uh, discussing hypertension, abnormal renal and liver function, bleeding tendency, labile INR, and drug or alcohol use. Aspirin and NSAIDs increase your risk for bleeding, and alcohol does the same thing. So drugs that you're going to think about for anticoagulation for patients with AFib to prevent strokes. Warfarin has historically been the first line therapy until DOACs came onto the market. We all know that warfarin is a beast of a medication to manage, and it has a narrow therapeutic window. requires frequent monitoring, and has a lot of drug and dietary interactions. But one benefit is that it does have an antidote, vitamin K. So if a patient is if their INR is too high, you give them some vitamin K. A target INR for AFib is between 2 to 3. Also consider a patient's vitamin K intake. If they eat a lot of leafy green vegetables, which is really good for them, they might need higher doses of warfarin. Or you might want to say, hey, back off of that stuff, maybe, if they're eating too much. And they're going to have to go to the anticoagulation clinic every so often. And I've also seen at home, like point of care INR monitors, and that's really handy. So they don't have to go maybe once every week or two. So then your DOACs include Eliquis and Xarelto, and there's a couple other ones. But they're now the first line treatment for patients with AFib, except in those with moderate to severe mitral stenosis or who have received a mechanical heart valve. These medications show a significantly lower risk of major bleeding. Um, they're easy because they only have like specific doses. So Eliquis, you have 2.5 milligrams or 5 milligrams BID. 2.5 is really if a patient is really small, over 80 years old, or has renal impairment. Um, 5 milligrams BID is the most common dose. Um, and then with Xarelto, you've got 15 milligrams in the evening with meals. Um, So the downside to those is they don't have a direct um, antidote, and it does take a while for them to become non-therapeutic. So if the patient's having surgery or something, you have to stop those medications a few days in advance. Um, if a patient's not a candidate for anticoagulation, a percutaneous approach to occlude the left atrial appendage is indicated when there's moderate to high risk of stroke and a contraindication to long-term anticoagulation. For example, severe bleeding, spontaneous intracranial bleeding, or recurrent falls. I went to a presentation on this. One of the devices is called a Watchman device, and it was put on by an internal medicine hospitalist talking about basically like patients that have AFib and when they come to the hospital on blood thinners, but have another reason to be there, like GI bleed or fall or anything where the blood thinners have kind of made it more complicated. And the Watchman is like a little basket device that sits, it includes the left atrial appendage that's placed in cath lab by a cardiologist, and it blocks the clots from moving out of that area. So a patient will have to continue anticoagulation for a few weeks after the procedure and then doesn't have to do it anymore. And it's really nice because you know how horrible it is when a patient goes to the hospital and hit their head on blood thinners. Um, and it puts these high risk patients in a, before they really didn't have a lot of options, but now this is a really cool thing that they can do instead. Follow up for your patients with AFib. They should see a cardiologist. They should be seen 1 week after initiation of antiarrhythmic medications. Every visit, you want to check adherence to medications, discuss signs and symptoms of bleeding. Say, keep an eye on your stools if they're not, let me know if they're dark. Um, Report like bloody vomit, coughing up blood, um, and things like that. And then medication review should be completed every time. You'll want to check an EKG and do an INR 3 to 4 days after initiation of warfarin. And here's my concept map, and that's got all the stuff in there that we've already talked about. And then here's my case study. So Mrs. Smith is a 67-year-old female patient who's here in your office today for a post-hospital follow-up visit. She was recently admitted to the hospital for 3 days for new onset AFib. She went to the ER for dyspnea and chest pain. Reviewing her records, you know her echocardiogram showed an ejection fraction of 60 to 65%. Her troponins were unremarkable. She underwent TEE in preparation for cardioversion, and a thrombus was noted in the left atrium. She was discharged on 10 milligrams of Eliquis BID for 7 days, then 5 milligrams BID after that, and metoprolol 25 milligrams BID. She is scheduled for an elective cardioversion in 3 weeks. She reports that she's feeling better, but is worried about being an AFib as it caused her mother to have a stroke in the past. She has a history of hypertension, hypothyroidism, and is a current smoker and has diabetes. Her vital signs today are as follows. Her rhythm is noted to be irregular on exam. So calculate Mrs. Smith's Chad's Basque score. Number two, what education would you provide to Mrs. Smith regarding the use of an anticoagulant? And then three, what lifestyle modifications would you educate her on? And here are my references, and that's it. Thank you very much for listening.